All right, hello and welcome to Albert Road General Practice's first webinar. My name is Simon Ashton. I'm the head physiotherapist here at ARGP. And can I just say I'm really excited to be bringing this discussion to our community. It hits on an area of research that I am particularly passionate about, and that is bringing research translation on best practice care to the community, to the general public, for the betterment of everybody, and particularly yourselves as the patients or the consumers of our healthcare system. I think this is an area that should do a lot of good for a lot of people. And the content really for today's discussion is inspired by an article by Ivan Lin and his colleagues. The article is titled "What Best Practice Care Looks Like for Musculoskeletal Pain," and it was published in the British Journal of Sports Medicine in 2019. The article itself, I have to get really excited and nerdy here. It is a great read. It's one of those articles that comes along every so often that really makes waves, and I strongly encourage everyone to read the whole thing for themselves, make their own opinions. There's a lot of really useful information in there. And basically what we're going to be doing is looking through the recommendations that the authors make, and providing you with that information so you can be further informed. So starting off, we're going to hit some baseline definitions, and we'd like to start off by clarifying what musculoskeletal pain really is. Believe it or not, that's not actually such an easy thing to define. If you've ever had pain and you've tried to describe it to a physio or to a doctor or to a friend, sometimes the words escape you, and sometimes the information is not really well received because we don't have a really strong communal common understanding. So the International Association for the Study of Pain is trying to help us out here. They've given us the definition that pain is an unpleasant sensory or emotional experience that arises from actual or perceived tissue damage to either the muscles, joints, ligaments, tendons, or bones in the situation of musculoskeletal pain. And then taking that even further, we can also identify the primary driving forces or the influencing mechanisms behind what the symptoms might be, which can be then broken down further into three classifications. So starting off with the first is nociceptive pain, which arises from actual or threatened damage to non-neural tissue, and is due to the activation of nociceptors. This is your really classic stub toe, pain signal goes up to the brain. We interpret that as a problem, and we act safely and accordingly to clear ourselves of whatever that problem might be. A really protective mechanism. The important word in amongst all of that is non-neural. So that describes that we're working with those bones, muscles, tendons, ligaments. We're not talking about nerves, whether that's in the central nervous system or the peripheral nervous system. So yes, of course, then we do have a type of pain that does relate to that kind of tissue, and which we would call neuropathic pain. Neuropathic pain is the label we use when there is a pain arising from a lesion or damage to the somatosensory nervous system. That probably best example of that one that would be widely recognized would be what true sciatica is. We've got other words that we like to use in physio world, but using that language, when there's either, say, adverse compression or tension on the sciatic nerve, it feels a very, very specific way, very easily distinguished from other sorts of pain, because it's a very, very classic set of clearly identifiable features. And other nerves in other parts of the body also feel the same way, so we can use that as neuropathic pain. And then lastly, we've also got a mechanism that can occur due to altered nociception, and that's a pain that occurs despite no clear evidence of actual or threatened tissue damage occurring in the peripheral nociceptors, or even a disease of the somatosensory nervous system or lesion of the nerves. And we call that nociplastic pain. And this one's perhaps one of the more difficult to understand. An example that comes to mind is fibromyalgia. It's a condition that is not terribly well understood at a mechanism level. There's not a very clear, obvious break, sprain, strain, tear, etc. And we've got these widespread, variable, unusual pain, weird symptoms that kind of come along with it as well. And that's kind of an example of perhaps when the processing system as a whole is more dysfunctional rather than just individual discrete elements of damage or perceived damage. So we can talk about those a lot more at length in later discussions, and I think I'd really encourage questions about all of that stuff, and they're areas that I would discuss with patients in the clinic. And we might just leave it there though, because it certainly opens a can of worms, and it's a big hole that we can get into. Basically, the important message here is that there's several different types of pain, and all of them are real. I'm certainly going to be the person that will say 100% belief that whatever you are experiencing, that's what's going on. Your experience is real, your pain is real, disability that you may suffer from that is real. The financial consequences, the social consequences, all of it is real. And we absolutely wanting to acknowledge that and support that, and hence these recommendations come to better enable the wider system to support people that have musculoskeletal pain of any mechanism, of any type, really. So with that said, we won't talk much more about what the pain is, but I'd now kind of like to almost take an opportunity to challenge the healthcare system as a whole, and even some unhelpful prevailing beliefs, and perhaps replace them with 11 more usable recommendations. It's recommendations that you could certainly be mindful of when addressing any pain-related issue, whether that's discussions with healthcare providers or when you're just Googling at home. You've got these thoughts. You may have pulled up sore after exercising. You may have had a trip, a bump, something like that, or something even just waking up one morning and thinking, this isn't quite right. They are basic recommendations that anyone can use at any time. Hope I've got that point across. So these recommendations come from an article by Ivan Lin. He, with his colleagues, conducted a major review of all of the clinical practice guidelines that were published on various musculoskeletal pain issues. And in doing so, they found over 6,000 articles that were on a wide range of different things, from neck pain, osteoarthritis, back pain, shoulders, knees, lower limbs, the whole lot. And after they did a very, very thorough screening process, they narrowed it down to a final set of 44 really high quality clinical practice guidelines. And just quickly, a clinical practice guideline is basically a review of itself, of all of the systematic reviews and all of the recommendations on the best way to treat any given particular issue. So what Ivan Lin and his colleagues have done is they've taken a summary of all of the clinical practice guidelines, which is a summary of all of the research that exists to inform those guidelines, and they've picked out 11 common recommendations amongst all of them. So this is a huge body of work. It's really, really cool. And the fact that they've come out with 11 really excites me. I'm hoping I'm getting that across to you guys, because yeah, it really it's bigger than what we could possibly imagine. It's bigger than the topic itself. This has really high or wide-reaching impact, and a lot of value for a lot of people, particularly something, obviously, guys, I'm really excited about this. So why is this necessary, I guess? You'd think that all healthcare providers and professionals are up to date and doing all the best things. But unfortunately, that's not the case. So Ivan Lin, bit of a backstory to their study. They've sort of discovered as they were researching these clinical practice guidelines, that there were a lot of inconsistencies and recommendations that really weren't fully up to date and up to scratch with what we know is best these days. They found themselves as a strong tendency to over-recommend medical imaging. And when I say that, I mean using X-rays, CTs, MRIs, ultrasounds and things like that sort of nature. And there was a over-reliance on or an early adoption of surgery, and certainly an overprescription of opioid medication. Now, they're not the first ones to have done that. There's been a lot of other authors and research groups who have come to the same conclusion. More often than not, you'll see that coming out on a specific body part that's saying that those statistics are going strongly in favour or towards, inappropriately towards surgery or opioid prescription, when we should be going much more towards conservative intervention and management. And unfortunately, that's not really happening. So it's not to say that those are bad. If we lean into those too early and inappropriately, it probably means that people are going to go into more invasive treatment options that will cost potentially extra time, extra money. It could prolong their recovery time. Basically, it's going to use up a lot of resources, both personally and at a systemic level through the healthcare networks, and really just delay the effective care and effective management and getting back on track and back into life, reducing that pain disability. So of course, I'll further say that not all imaging, surgery or opioids are bad or unnecessary. There's definitely a time and a place for those. What we see in other areas of research that there's, particularly in the emergency department setting, there is an over-reliance on imaging or inappropriate use of imaging. Certainly an emergency department is a place where we think people presenting would need that sort of stuff, but even in that setting, it isn't always the case. We need to be very judicious. We need to be very highly justified. We need to make sure we're making the right recommendations at the right time for the right people. So we avoid any sort of extra harms, extra costs, and added consequences. So taking a deep breath, regardless of the actual intervention, care that is in line with best practice recommendations is proven to be able to achieve better outcomes at a lower cost. And that may seem really bizarre to hear. It may seem really self-evident. But the fact that we are seeing increased surgeries and increased opioid prescription suggests that we're not following clinical practice guidelines or the best recommendations. And if we do, we'll achieve better results, which is a win-win for everyone. That's why these guys have made this article. That's why we've got these 11 best quality recommendations. And you know, there's reasons why different providers may not be adhering to them. There's a lot of pressures in the system. So we're not here to point fingers. We're just saying that there's certainly room for improvement across the board. So beauty in these recommendations is in their simplicity, their appeal to common sense, and the degree of high quality evidential support. Anyone can have these recommendations in the back of their mind when seeking professional care. And as I've said a few times now, I strongly encourage that open conversation. And it's a conversation that I have with my patients, particularly around the use of opioids and medical imaging. Those are two things that certainly patients come in being really concerned with something that they've got, or the pain is kind of out of control. They're seeking something that is going to interrupt that cycle, something that's going to explain what the problem is. But perhaps we're just jumping into those measures a little bit too quickly, and perhaps there's some better things that we could do to give answers or to find relief and find comfort in these recommendations that are about to come. So I'll just get straight into it. Number one, first recommendation off the bat is care should be patient-centered. It's a really good one to start with. And my interpretation of that is really that healthcare professionals should be acting as a supportive guide. And I really like that analogy. We're there to guide, and able to, at the same time, acknowledge and respond to individual context, what their expectations are, their preferences, really working together on a shared decision-making model towards what it is that's going to work best for that individual. And there are challenges with this one, though. The challenge is that many patients come to us, or as healthcare professionals, they come seeking expert advice. They may not have a strong opinion, they may not be terribly well educated in what the issue is, and that's probably the case most of the time. Not everyone out there is a physio or a doctor, and that's fair enough. That's our job, that's what we're here for. But I think the core of this is that really we want to be working collaboratively, working as a team, and the health professional working as a guide rather than as a dictator or as that authoritative source that says, this is what you've got to do, this is how you've got to do it. Basically, just trust me, I'm the expert, here's what you have to do. It sort of closes the conversation. It doesn't lead to really deep understanding. And as we further understand things, we can play with them. We can explore those concepts. We can break down any fears and worries that are associated with them, which could be really, really significant. So next one is perhaps a little bit more clinical. I'm speaking to the clinicians perhaps more out there. Is that patients should be routinely screened for serious pathology. That may be through blood tests, it may be through x-rays, it may be through some of those more medical type testing. And it's a really important rule to remember as we progress. Sometimes there really is a specific need for a specific assessment for a specific treatment. Again, it sounds really obvious, but most cases don't require it. The statistics for those sorts of conditions, those sorts of really nasty pathologies, are very, very, very small. They're rare. It's why we don't see them a lot. So have some sense of comfort, patients out there watching, that we as healthcare professionals are definitely keeping an eye out for the worst case scenario, but overwhelmingly the odds are that that's not going to be necessary, or it's not going to be important. Number 3 is psychosocial factors should be assessed and managed. So simply put, I would say for this recommendation is that our mind and our bodies don't exist in isolation. Our mind and our body are one. I think the biopsychosocial model of health has been around for decades, but it still needs promotion. We still have too many people out there that think there's a separation between it, that mental health doesn't affect physical health and vice versa. Certainly it absolutely does. And something that really speaks to this is a feeling of a headache. I'm confident that no one would believe that their brain would be damaged in any kind of way, or the head is damaged in any kind of way. But we certainly have pain up there, and that pain, when we perhaps have a headache, could be worsened by stress, by emotional things going on, by whole little life factors that might be contributing to that feeling. And certainly would be relieved by rest, relaxation, meditation, things of that nature. So it kind of creates this disconnection between what pain is, as we learned before, and the relationship to our physical bodies. They're very complex. It's not entirely reliant on what's going on physically. There is a strong, strong, strong emotional and psychological contribution. So I guess thinking of another analogy here could be heartache. Heartache's a really interesting one. It can manifest as some of the most intense physical feelings you've perhaps ever felt. Hopefully you haven't all felt that, but if you have, certainly that's an emotional, that's a psychological origin of that pain or that discomfort, whatever those physical symptoms are coming from the mind. So many emotions have physical manifestations. Stress and fear and worry, anxiety, they all come with deep visceral feelings. They make us feel physically unwell or in pain in some circumstances. So to think that we would just be assessing the physical nature of someone's pain definitely isn't enough. We need to be understanding their psychosocial. So what's going on with them mentally, emotionally, and socially is super important, and your healthcare provider should be assessing and at least recommending different ways to go about getting help in those domains. Next recommendation number 4 is that radiological imaging is discouraged in most circumstances. So unless there's an obvious clue that something weird is going on, or there's a trauma that's blatantly there, or there's a high suspicion of something weird or a trauma, such as like a high impact accident, sports accidents, falls, trips, bumps, car accidents, things of that sort of nature, we would clearly lean into x-rays. But when there's someone that's just woken up with a stiff neck, a sore back, that they're not the times where we should be jumping onto X-rays and CTs and MRIs. So perhaps the biggest culprit on the list, as well as in the medical world, for professionals, is we become too reliant on scans for a diagnosis, and maybe that's a big contributing factor to why we're making this sort of recommendation now. We want to avoid going into those areas where we're going to expose the body to radiation, and no one wants that unnecessarily at a very simple level. I think an important thing to pass on here is that the X-rays and CTs are not very good at explaining the physical symptoms someone has. An analogy that I would use in clinic would be, it would be like you trying to understand somebody's emotion just through a picture, or even you guys trying to sense the emotions that I'm feeling. What's my day been like? Have I been stressed? Am I tired? Do I have depression, anxiety, any of those sorts of issues internally? Hopefully I'm sitting here and looking happy and enthusiastic about this, but whatever's going on behind the scenes, you guys won't have a clue. That's not a cry for help. It's just an example that don't judge a book by its cover, I guess, is the phrase that you'd best use here. So certainly judicious use of medical imaging is super important. Next recommendation is to thoroughly physically assess the individual in front of you. And this is where we get to establish patterns and scrutinize those patterns against possible causes of pain, the types of pain mechanisms we spoke before. There would be clues as to those serious pathologies. There'd be all sorts of information that we get from a physical assessment. And it's what would be weighted probably second to the explanation of the story, the experience of that person, their subjective information. So the subjective information would come first in the weighting of the information that I would rely on. Then there would be my physical assessment, because many times we're going to provoke something that maybe wasn't quite known about, or the person was a little hesitant to test, and then we can really get in there and find out what's going on. So really it's a confirmation of the story that the individual has told us, and that can help to guide the further assessments. It can guide the starting point of therapy and rehab, if that's the direction we're going to go. And certainly the intensity of that rehab would be guided by the physical assessment, the information we get from that, of how sore someone is, how tender they are, how irritable that person's symptoms are. We're going to be very mindful of the clues that we pick up in that physical assessment, and use that later down the road. Moving on, we we need to progress and monitor the person's journey from start to finish, and we would do that through the use of objective outcome measures. There's a whole lot of different ones that we can use for this, and they're all really, really reliable and valid at helping us to track and monitor your progression or lack of progression over time with any particular issue. Certainly for all sorts of issues, whether it's all the way from fatigue to back pain, anxiety to ankle sprains, we can monitor it, and your health professional should be, so that there's some very clear and defined measures in time that'll show us the direction that you're heading. And next on the list, it's important to ensure that the patients and yourselves and the community are adequately, or hopefully more so, thoroughly educated about your condition and the best management strategies for what's going on for you. I think this one's actually quite huge. And it means that we need to be passing on information so that you fully understand what's going on. You've got that informed consent about the procedures or treatments, therapies that have been proposed to you. You can make the decision on whether that fits your values and what your goals are and what you're trying to achieve. And it also means that really we can't just simply talk our way through pain or out of pain. We've tried that. It doesn't it doesn't work terribly well. Understanding pain does make good improvements, but it's not the entire treatment to itself. And we know that when we add elements of education to traditional physio, whether that's hands-on work or physical exercises, anything of that kind of nature, we get a better outcome when we combine everything together. So it would be a combination of advice, exercise, and then ongoing support in sort of their progression of their rehab and their maintenance of the gains or progressions that they make. So moving on now, again, we want to provide management that addresses physical activity and exercise. Physios, we love this stuff. I love this stuff. Honestly, we could probably all do with getting out there and moving more and doing more in terms of when it comes to getting more benefits from general exercise. I ride my bike about 250 Ks a week, and I could probably still get more benefits from exercise. So I'm probably not alone on this one. Now, it doesn't mean that you need to go out there and ride the same kind of distance. You don't need to start training for a marathon. It's little things as taking regular breaks to get up and move, taking the stairs, walking to work occasionally, choosing to ride the bike occasionally. We get so much benefit out of that from generalized cardiorespiratory, neurological, metabolic, musculoskeletal, physiological, and social reasons as well, and probably even economical reasons to get out there and move more. And really the best in this is that you don't need any more coaching. You probably don't need any more equipment. You've probably got everything that you need at the very least to just get up and move around. So that one comes out as a really quick and easy win. That won't cost you anything to get all of the benefits that we can from moving more. And even just quickly coming to mind, using a standing desk throughout your week could be as beneficial as doing a whole hour-long exercise session once a week. So quite a bit of benefit to be gained from just getting up and doing things more. Now, utilizing manual therapies only as an adjunct to other evidence-based treatments. This is a contentious topic. This is hotly debated in the physio space. My opinion is that change is in the doing, and the doing is done by you. So often in physio rehab, we're looking to make changes to the capacity and the tolerance of the sore body part or the body region. And building capacity means increasing its ability to handle and tolerate the activities that you have in mind for it, the loads, the stresses, the strains, the effort that we place on those particular body parts need to be improve through physical means. Now, don't want to confuse that with improving the tissue quality so much. We're not looking to make, to demonize any sort of tissue quality, but we can certainly improve the tissue capacity. No amount of weight training makes my body look any bigger. I really struggle to put on muscle mass, but I certainly get the benefits from getting out there and lifting heavy things. My back feels a whole lot better for it. My knees and hips feel a whole lot better for it. My shoulders as well. And it's really no physical appearance that's changing. It's just the capacity of those tissues and the system as a whole that benefits. So, lost my place here. Lost my train of thought. I'll move right along. We'll go to number 10. So unless there's a clear reason, we want to utilize evidence-informed, non-surgical interventions or therapies to their fullest extent and their fullest potential prior to jumping down that surgical pathway. Surgery, not just speaking from my own opinion here, this is an objective fact from the literature that we have. In many cases, surgery is more expensive, and it's no more effective than conservative interventions of your typical physical therapy interventions, exercise and manual therapies. And it's perhaps a nuanced decision that needs to be jointly made between yourself and the healthcare professional as well. So it's not as simple as when something goes wrong, we just go in there and we staple it back, or we cut something out and do something like that. There's pros and cons to both sides of the story. And as I've been saying all along, this one really brings forward the discussion between the individual and the healthcare provider about what's going to be best for them. Certainly there are some people, those aspiring athletes, particularly if they're younger, they're going to try and get back into that really high level of performance again. They might want to lean into surgery after they've had some sort of injury or accident. But for the majority of us weekend warriors and mortals, regular people, often I would say conservative is going to work out better. And in many circumstances or studies even, we are seeing that conservative interventions are equally as effective 1 to 2 years out. Even further than that, going down the non-surgical route, we're seeing benefits. So into our last recommendation, that is to facilitate continuation or resumption of work and other meaningful activities as early as possible. And this is something that I emphasize a lot during consults. I always ask why the patient is there with me today, and without fail, more often, the answer is going to be to relieve pain. But I want to know, that's okay, you've got the pain, but what's that pain preventing you from doing? And how can we get you back to achieving that really meaningful activity? What is it that you've given up? What was that real reason for coming in to see me? There's something you've lost, and we want to help you get that back. I guess one question that sometimes ask if we're struggling with that concept would be, if I could wave that magic wand, if I could get rid of that pain, what's the thing that you'll be back to tomorrow? What are you going to be doing? That's that real meaningful activity. That's the target. That's the finish line of getting you to that point. And I think it's something that all of us as health professionals should be going a little bit further to understand the real motivations and driving forces that bring people into healthcare to seek assistance when they do have those pain problems, because it's going to be more than just the pain. It's going to be that's impacting your life to some degree. So certainly come into your sessions with a good understanding if you can, if you've identified that, or if you don't, seek out that sort of problem solving and brainstorming with your health professional to really figure out more so than just the pain, what's going on. Well, it's been a lot of talking. It's time to catch a bit of a breath here. There's so much more that we could pull apart in each of those recommendations. But I'm hoping that laying it out in this form for you today will hopefully lead to better outcomes. It can lead you to being better informed about your healthcare, so you can be more involved. The more involved you are, the better your outcomes will be. We know that, as we said before, if you adhere to the best recommendations, you're going to be seeing better outcomes than others. So in finishing, as always, our promise here at ARGP is to be positive, passionate, and progressive in our care to you. And these 11 recommendations are a really great example of how we stay true to that ethos. They're something that I, as I said before, hold really true to heart. They're always on my mind when I'm dealing with my patients, because it's really a way of a framework of getting the most out of each session and really finding the value in that person's life and getting them back into that point without unnecessary cost, unnecessary resource usage. And I hope that resonates with you guys. So with that said, a big thank you for staying with me all the way to the end. I have a tendency to rabble on, and I've lost myself at least once in there with deep in thought. But it really has been my pleasure in giving this presentation to you. Very excited to be doing it. I hope to be giving more in the future. If you could share this with your social networks, if you can let people know about it, let people know about us, and the type of work that we're trying to do, the goals that we're trying to achieve in improving research translation, in terms of improving patient outcomes, improving the healthcare system as a whole, even just improving myself as a physio, holding myself accountable, putting this information out there with the way that I practice. It would be greatly appreciated. So don't be strangers. Get us out there. Come on in. We'd love to meet you. We'd love to help you out with whatever the issues are that you've got going on. And now you know a bit of a framework on what's in my mind and how we'd go about that. So thank you very much for your time, and I'll end things there. Ta.